Good morning. We are into the next session, that's Ophthalmology Decoded. Dr. Mahesh, along with me, are on the stage as chairpersons. This is a session where the senior ophthalmologists from all over India share their experience with our members here. To start with, we have Dr. Satyan P. He's a renowned glaucoma specialist from Coimbatore. Satyan will be talking to us on gonioscopy. Over to you, Satyan.
Very good morning to all of you. Thank you, KSOS, for this opportunity to be here. Doing the gonioscopy is basically an attitude that we have to have. So gonioscopy in ophthalmology is very essential. It can help your diagnosis. It's useful for your therapeutic option and also to assess the prognosis. When you're looking at the anterior chamber angle, most of the time it is for the medical management and for the surgical procedure, the anterior chamber angle is critical. Looking at the anatomy of the anterior chamber angle, from anterior to posterior, you have the small base line, then you have the non-pigmented trabecular meshwork, then you have the pigmented trabecular meshwork, then you have the scleral spur, then you have the ciliary body band. If you don't know this, then there is no point in you doing the gonioscopy, so this is very essential and critical. So doing the gonioscopy, so we know that the gonioscopic status is a very, very dynamic one. It is not static, as there is a lens changes, medication effects, aging process, and the disease process. All these things can alter the gonioscopic picture over a period of time. So there are two different methods. What we commonly do in the OPD is the indirect gonioscopy, and what we do in the operating room is the direct gonioscopy. So in the indirect gonioscopy, we just have to understand this. It's a mirror image. Whatever you see in the mirror is the opposite side, but the side is not reversed. Right is right and left is left. This is many times we have this confusion, so this is again critical for us to understand these basics. So in the indirect method, there are different type of lenses are available. One is with the flange, the other is without the flange. So what is this is all about? The one with the flange, you need to use the coupling solution, the viscoelastic solution, as the radius of the curvature of the lens is smaller than the radius of the curvature of the cornea. So you have to use this viscoelastic solution. You can see the flange in this. Then the other one is, you can see the radius of the curvature is about 8.4, which is much more than the corneal curvature. In this, you don't have to really use the viscoelastic solutions. Both the lenses can be comfortably used, but if we want to do the recording purpose, then it is better we go for the one which has the viscoelastic solution, that is with the flange. So whenever you are doing the indirect gonioscopy in the slit lamp, what are the prerequisites? It is optional that if you want to have on handheld, the rest, you can use it. Then of course you need to have your viscoelastic gel, the gonio gel solution. Then you need to have the local anesthetic agents. Then the type of lens which you want to use it, the indirect lenses of your choice. But basically I use a SLT lens which gives you a much better view than your regular gonio lenses. Then of course you can use your the handheld lens also. Whichever is your option, you can always take it and use it. And of course you have to have the tissue papers for yourself, for the staff, and for the patient, as we know that it is going to leak over there. These are very practical things. So the first step is you fill up your the gonio gel in your lens and make sure that there is not much of an air bubble. That is the critical one. If you have the air bubble, the visualization of your angle becomes very difficult. So make sure that there is no air bubble. That is the step number one. Then the next step is applying the local anesthetic. I basically use a proparacaine, 0.5%, 1 drop. Then wait for just 15 seconds to 30 seconds for it to numb. And then the next step is preparing your patient for the slit lamp examination. So make sure that the patient is sitting comfortably without much of a head tilt, and ask the patient to look up. That is going to be, adjust your slit lamp, make it comfortable. Probably you just turn your slit lamp to the temporal side about 60 degrees. So the angle is very comfortably visible for you. So when you are taking the, ask the patient to look up, that is very important. And just make sure that you see the lower part of the sclera comfortably, and then just push it in, and then rotate the lens so the mirror is on the top. The reason is the broadest or the widest angle is the inferior angle, so start seeing the inferior angle first. Then once the procedure is over, then how to take out the lens out. Ask the patient to gently close the lids or sometimes little bit more so that there is a vacuum created inside, the air bubble goes in, then easily it comes out. That's how you, so this is how usually the angles are. The lower part is the widest angle, so you can comfortably see. The narrowest is the upper part. Then if you take a typical angle closure disease, usually the narrowest is on the temporal side. So this is how you start seeing. The moment you put the slit is height is more. So immediately you just reduce the height and also switch off the lights in the room so that the room becomes a little bit darker. You don't have to really completely darken it. And then starts widen the slit. It is the height of the slit is reduced to the minimum, and widen the slit you can see comfortably, and also increase the magnification. The first step is to see that the wedge, the corneal wedge is the first thing that you should look for, so that you don't misidentify the Swalb's line as a trabecular meshwork. That is the first part. So this is how you start seeing the lower angle first, the inferior angle first, and then nasal, inferior, and then comes to the temporal. So you can use the other lens, the handheld lens also you can use it. You don't need a gonio gel in this, but I am not too happy to do this because you don't see much angle structures in this as good as what you see with your single or two mirror lenses. So this is how you hold, but little bit of a cross angle, you hold it, then you can see the angle much better than holding it like a plus. So this is how you can do. So anatomy recap, Swalb's line, trabecular meshwork, scleral spur, and the ciliary body band. So I just thought I'll share you some of the pathologies in each area. Swalb's line, if you say, how to identify the Swalb's line, as I told you, you can see these two slits here, one in the front and one in the back. Where it joins is the corneal wedge, that is the end of the decimates. That is where the Swalb's line starts. So first thing is you identify the Swalb's line so that you don't miss the pigmented Swalb's line as a trabecular meshwork. So many people used to say that they have done SLT, but they might have done it only in the Swalb's line. So this is a Swalb's line, pigmented Swalb's line, otherwise called as a Sampolisis line in a pseudo-exfoliation glaucoma. Then you have the trabecular meshwork. You can see that this is a uniform 360-degree pigmentation of the trabecular meshwork. That is a very typical of pigment dispersion syndrome. So you should not get confused with the Sampolisis line and the pigmented trabecular meshwork. Usually the trabecular pigmented meshwork is very irregular in pigmentation and it is rough. In children it is very lightly pigmented, or sometimes it is very glistening. It is not like a very pigmented layer. Then comes the scleral spur. This is a very white band there. This is very critical structure in the anterior chamber angle to decide most of the other areas. So scleral spur is extremely important, especially when you are doing the OCT, the scleral spur is important. So you can see here over the scleral spur, you can see the blood and also the NVA in the angle with a little bit of a hyphema over there. Iris and ciliary body. Then you have mainly you have to understand these iris processes. These are a filiform like vessel like pattern, brownish in color. This will not obstruct the flow. But when you see the PAS, you can see how broad it is. It is broader, but it obstructs the outflow. So these are the two main things that we need to understand: iris processes and the PAS, how to identify and what happens. The next one is this is a traumatic mydriasis. You can see that ciliary body band, how wide the ciliary body band is, pigmented trabecular meshwork. Then you have the ciliary body band over there, how wide it is. So it is a dark grayish band, large area of the ciliary body band. This is a typical angle recession glaucoma. So manipulation gonioscopy, there's a small one on this. So when you are asking the patient to look up, then you can see that the angle widens. Towards the mirror, you ask the patient to see towards the mirror, then angle opens up a little bit, so that is called as the manipulation gonioscopy. In post-operative conditions, the gonioscopy is again very, very useful. You can see this is the ostium, you can see the two pillars on that iris, which is coming into the clogging the ostium, but it is not completely clogging the ostium, so it is quite useful for you to understand what is going on over there. You can see this is a pseudo-exfoliation glaucoma where I have done a trabeculectomy. But you can see very little hyphema, which I missed. But when you can see the ostium, it is oozing from the ostium. Both the sides of the ostium, it is oozing from there. So that is very typical of pseudo-exfoliation glaucoma patients. And this is again post-trab ostium. This is open. Only a few pigments are there. So the cause is not from the ostium, it is somewhere else. The problem is from somewhere else. So I'll just take few 10 seconds I'll take. So you can see in this again, the ostium is completely clogged by the iris. So again, the cause of failure we can easily understand and identify and treat the cause. So gonioscopy is again an attitude that we have to develop to diagnose our therapeutic options. Based on that, you can use it for prognostic as well. So thank you so much for your patient listening.
Thank you, Dr. Satyan. That was a master class. I have a question for you. In an inflamed eye, let me say it's a post-vitrectomy eye with oil. The patient has had a shallow AC. A YACP eye was done. The AC is formed, but still the IOP remains high. In such a condition, what gonioscopy would you advise?
See, as long as your cornea is clear, you can use
Anything.
all gonioscopes, provided that you are comfortable in using the one which has a flange. Because with the flange, your visualization is always better. But without the flange, you can use in those kind of complicated conditions, you can use those with the radius of curvature is much larger. So that will be very comfortable for the patient and for you also. Though it's inflamed eyes, it is better to use without gel. Handheld, you can use it, or you can use the modified Goldman also. You can use it with a single or two mirrors. You can use it definitely.
This emulsified oil particles in the trabecular
Angle
will look. How will it look? It will.
So that is a very fancy video. I do have one because that is obviously seen. So these things which we really don't see with your naked eyes or the slit lamp is the one which I really wanted to show in this. But that is a very fancy picture. We always try to show the angle foreign body. Of course, small angle foreign bodies, definitely gonioscopy is important. But silicon oil is always seen in slit lamps comfortably. Then you don't really have to use a gonioscopy to pick up the silicon oil. Those kind of very tiny silicon oil bubbles in the angle, it really may not be the cause for the increased intraocular pressures. It is more of a tight band or something else is the cause.
Yeah. Any question from the audience? If not, we can go to the.
Yeah. Thanks so much again.
Thank you.
And
Thank
I repeatedly say this word all the time. Doing a gonioscopy is an attitude. Please do develop that. Thank you.
Thank you, sir. I request Dr. Ramamurthy for giving his talk. Dr. Ramamurthy does not require any introduction. So, it is, he will be speaking on value addition, that is making yourself sought after in the job market and preparing for starting your own practice. We are looking forward to your.
Thank you. I'll be speaking on value addition for a young ophthalmologist. The complete topic looks more like a sales pitch as to how you prepare yourself for being accepted, etc. So let me talk about what exactly. I hope there are quite a few young ophthalmologists here. Some of these would come from my own personal experience because I think it's relevant, and it's just a series of dictums that I've followed in my professional lifetime, and it has helped me. The two gentlemen who have influenced me a lot is one is Dr. S.S. Badrinath, Emeritus Chairman of Shankar Nethralaya, who unfortunately passed away recently, and Shri Murthy, Narayan Murthy, again Emeritus Chairman of Infosys. According to their own confessions, they had very humble beginnings, not even extraordinarily brilliant academic career, but they built up institutions of international relevance and importance. Obviously, it's because of the they dream big. When Dr. Badrinath came back from the US and was working in a small clinic in HM Hospital, he still had the vision to go ahead and pursue lifetime's ambition of building an institution. And so was with Mr. Narayan Murthy. And recently, Mr. Narayan Murthy even got into a controversy because he said that young people should work 70 hours a day. But that's his concept. Maybe you do not agree with him. But daring to dream big and then striving extremely hard to achieve it is extremely important. I think these two gentlemen have led by example in that. And no success comes without hard work. Maybe brilliance, extraordinary, being there in the right time, in the right place is important. But anybody who has been successful in life has worked hard for it. The four young ladies who see in the front may be striking to the eyes, but the one you would remember from the picture is the lady at the back. That's simply because she is different. The fact that secret of business is to know something that nobody else knows was said by Aristotle Onassis, whose claim to fame lies not only in the fact that he got married to Jacqueline Kennedy, but also to the fact that he was an extraordinarily successful business tycoon, shipping magnate. And the fact that this applies in ophthalmology also. And almost at every step of my career, I have striven to do this. When I started off my ophthalmic practice in a small town of Tirupur, when I got a slit lamp, it came in the papers for the simple reason that was different at that point of time. Examining the eye with a microscope is what they said. But fluorescein angiography, YAG laser, fundus photography, argon laser, all these things which are extremely commonplace today, made news at that time. Deputy Chief Minister of Tamil Nadu, because of the connections the hospital I worked in had, was there to inaugurate these machines. So obviously being the first mover gives a great advantage. I often recount this. We got the Chiron 217C LASIK machine in 1997, exactly the time when Arvind Eye Hospital, for whom I have the greatest respect and regard, opened their center in Coimbatore. It was unheard of in those days to think that somebody would spend $500,000 in a small practice to buy a machine of this magnitude. But then it did help us to differentiate ourselves, and once we had this facility, it was not just the patients who came for refractive surgery, but for cataract, for the retinal treatment, for the just an eye examination. That's simply because we are different. And this being different varies from time to time. Only because you have done one or two things that you can't stop there. It is a continuous process of evolution where you keep updating, upgrading, and giving the best of technology and techniques to your patients. And this does not just refer to building hospitals or buying equipments. In case you are in an institutional practice, publishing more and more, enhancing your skill sets, going on to peer-reviewed literature, attending, making your presence felt internationally. Always you should be aiming high, and that's one way that you'd progress. This slide I used yesterday also, and I believe this is extremely important for me. And you may be a small practice, you may just have 4 people working with you, or you might have 1,200 people working with you. But it is extremely important to motivate the team, guide them. As far as they share the vision that you have for the institution or for the small practice, your life is made. And we often concentrate on selecting equipment, upgrading them, etc. But then it's even more important to get the best of people around you. I'm not talking only at the consultant level, but right from the person in the reception, the sister who takes the patients around. If each of them is devoted, each of them feels a sense of ownership in the institution, then that is what leads to the success of that particular place. This is something which is always maintained, that if you have to get the right quality, you have to pay the right price. The converse is not necessarily true, in the sense just because you are paying a high price, that doesn't mean that you would get high quality. But then, whenever it comes to personnel, infrastructure, or equipments, then you might have to balance this out, and once you have the equation right, most often you would find that you are quite successful in what you're doing. This is again an important slide in the sense that no matter how large your company is, treat customers as if your survival depends on them. It does. Today, medical treatment, is a service industry. People consider that they are paid a certain amount and they are eligible for a certain quality of treatment, certain quality of outcomes, and need to respect that and meet them. And it is not just the few minutes they spend under the microscope alone that's important, but the entire experience from the moment they enter the hospital to the moment they walk out. So treating not just the patients with a complicated vitreoretinal surgery or who has come from an expensive refractive surgical procedure, but treating every patient as if they are a guest in your center is extremely important, and that's where the success of the place is dependent on that. This is just a carryover from already what I said. Wow, the person you see here is an optometrist who has been with me for 35 years. I think there have been oftentimes situations where a young child, a 10-year-old, has been prescribed glasses. In a busy OPD, the parents insist on seeing me just because they think it's the end of the world. It's sometimes irritating because you have bigger things to do. But then taking those 2-3 minutes of talking to the parents, it's not the end of the world. You can wear these glasses, use atropine eye drops. All this my pediatric ophthalmologist would have already done. But reassure them, tell them once the child is 19, 20, there are even ways and means of getting rid of this. Is often extremely reassuring. It is that parent who gets his father to me for cataract surgery, his uncle to me for retinal detachment, and his elder daughter for a LASIK treatment, because I have gained the faith, gained their confidence that if you come to this place, they're going to take care of you. Maybe this is the most important slide of my presentation. I think the secret of life is honesty and fair dealing. If you stick to that, you have got it made. An anecdote, young father with a 5-year-old got into a bus along with a friend. The law of the land was if the child was above 5 years old, you have to buy a ticket. When the conductor came, the father said 2.5 tickets. He went away. The friend chided, the child looks so small. Why did you say 5 years? The conductor would have never known. The father replied, the conductor would not have known, but my child would have known. Basically, you're being constantly observed. You have to lead by example. Your peers, your wife, your spouse, your children, everybody is looking at you, and it's the example that you said that they are going to follow. If I were to charge for an imported lens and put an Indian lens, if my OT assistant takes away a few lenses, obviously I can't find fault with him. So being honest is not because I'm a Gandhian or because I believe in I was told to be honest in the social studies class, but I think that's what works. If you tell a lie, it's difficult to maintain it. But if you're honest right through, that is something that works, and especially in practice, it's extremely important that stands in good stead. Any excellent institution that you see around which has been successful, you'd find that the core values is ethical practice and honesty, and that's extremely important. The glory is never in failing, but raising every time you fail. We started a branch in Patambi, a small, I'm sure you're more familiar with the place than me, and in a good multi-speciality center. Tried for about a couple of years, but then the people were extremely nice. They actually got us over, they promoted us, etc., but didn't work. We cut our losses in a couple of years, we moved away. But can I take a minute or so? Cut our losses and moved away. This was failure for me. And so many times, I'm sure surgical failure, so many things we face in our professional practice. But each time you feel there is a lesson to be learned. And the best lesson I learned from this is that what exactly is not going to work for me. And obviously when we do, whether it's cataract surgery or refractive surgery or complex vitreoretinal surgery, there are errors that you commit. And better than learning from these conferences, I think reviewing your own surgical procedures, what exactly went wrong, and learning from that is extremely important. Again, there's always an attraction. I think it's fast dying down, thankfully so, in the sense that people want to come to Cochin, Trivandrum, Bombay, Delhi, Chennai, like that, the metro cities. But then some of the best institutions in our own country which are performing yeoman service is in smaller centers. Chitrakoot, Dr. B.K. Jain was here. He has been given, I don't know whether you have heard about it, has been given a very large piece of land in Varanasi by our own Prime Minister to set up an ophthalmic center of excellence. And Chitrakoot, when I went there about 8 to 10 years, from the station after getting down, it takes 3.5 hours of rough ride to reach there. And obviously, you can perform very well. Now there is an understanding, there is a need for centers of excellence even in remote places, and not necessarily confining your practice or you are joining an institution in metro cities, but heading out to the tier 3, tier 4 towns is also a good idea. The final slide of my presentation, if we throw a stone in Coimbatore, you will invariably hit an ophthalmologist because they are surrounded by them. But it has not constrained our growth. What we look at is how many surgeries we performed the same month last year, how many what was the turnover in our opticals, what was the number of vitreoretinal surgeries that was performed, how well did our PGs do, how many papers was published, what kind of presentations was made. So you have no control over who is going to come into your town to practice, set up a practice, how well they are going to do, what kind of equipment that they are going to acquire. What you can control is how you perform year on year, decade on decade, improving yourself. The standards that you set is what you performed the previous year. Get better or get beaten. So said Jack Welch. Thank you so much for your kind attention.
Thank you, sir, for your words of wisdom. That was indeed great, speaking from your experience. And the word which you passed on, any number of sermons can't change you. Walk your talk, it can change your life. Thank you, sir.
Thank you.
Any questions to Dr. Ramamurthy? Thank you, sir. If not, we'll go into the next talk, that is by Dr. Krishna Prasad. He's a very familiar figure in KSOS. Dr. Krishna Prasad has been here with us for so many conferences. Today he'll speak on changing narratives for scaling up your cataract practice.
Good morning. Thank you, KSOS, for having me here. See, our belief systems and our mindset actually decides the narratives that we keep believing, keep telling people. And that is also true for our practice, especially the cataract practice. I've been thinking for the last few years, like how the way we think, the way we believe, and the things that we have fed over years actually change the way we actually practice and we talk to our patients. See, I'll restrict this to talk to a phacoemulsification surgery, which is the main bread and butter and probably the very sole purpose of our existence. We have evolved in the last 30 years. I still remember when I joined RP Center 30 years ago in 1992. Like there was one mission, Dr. Mahipal was here, was the only solo phaco surgeon that he was doing, and we saw from there it was a 3.4 millimeter scleral tunnel incision, and there was only one lens available from Star to put there. So from there, and it was under a peribulbar block. From there, our techniques we have perfected, and the technology also has come by, and there is a marriage of these two to create probably, and today I think most of us will agree, that we have come to a stage where we are really doing a very good job. Our patients are having a very rewarding experience. The whole cataract surgery experience of a topical phaco is really remarkable, that we have really reached some stage, and this probably evolution is still continuing, but at this point of time we can be really doing that. But what has changed in last 30 years is that the topical phaco, see this block surgery under a peribulbar block is a game changer. We always think both are okay, anyway we are doing it for the sake, we can give a block. But please understand, for the patient, it makes a big difference. If the patient can get a surgery under topical anesthesia versus a peribulbar block surgery, it's a hell and heaven difference for the patient. So topical phaco, since we are able to do under topical, that has been the biggest advantage of phaco over maybe SICS or ECCE. It's a quick surgery. Most of the surgeons, experienced surgeons, take around 4 to 5 minutes to complete the surgery. So this Very short surgery is very important for patients who have systemic problems and stress-related problems. So quick surgery has been basically the advantage towards the patient, and the difference is the T-leaf should. We just enter the clear cornea and we just finish off the surgery. We don't touch the iris. So there's a very minimal corneal damage because we don't get the nucleus into the AC and take it out. We just break it up. At the same time, we don't touch the iris, and a shorter surgery. So we always have a very minimal inflammation. So which actually we don't have to use too much of post-operative steroids. And what has changed is the biometry. That is, everybody agrees that the latest optical biometers with all the formulae that we are able to have a bang on the post-op result that we want. And we have understood how to work in very extremes of axial lens. And this evolving science that we are keeping abreast with has really made the surgery very predictive so that we can really experiment and build on this. And we have this PC IOL today is not posterior chamber IOL. This is for the postgrad. This is presbyopia correcting IOL. The present stock of presbyopia correcting IOLs that we have has been an excellent thing that has happened. We have a lot of lenses with better light transmission. And also the Indian economy has changed. Now the people are ready to pay out of pocket, out of insurances. Now there is a health spending on the eye. It is no more something which can be related to the overall mass surgeries in the camp with a low cost, quality surgery. It is where people can spend for the most important part of their life, that is the quality of vision. And what has not changed is our attitude. I think we still are under the hangover of taking cataract surgery as a sight restoring surgery where a person comes as blind and we do the surgery or whatever technique and patient starts seeing. It is something that we commit a lot of mistakes in our narratives. One thing is, it's only for an opaque lens. We always do a condescending comment, on somebody who is doing a surgery on a clear lens. Clear lens extraction is a very condescending word, like California cataracts, or people who do for basically money's sake. Even though there is no cataract, you just do a cataract surgery. No. Basically, you understand the lens becomes dysfunctional after some time. The very fact that the patient develops presbyopia by 40 to 45, itself the lens is not able to deform the way we want. So the presbyopia is the leading thing now. This is going to drive our decision making in future. With all the availability of gadgets, the need for near vision for all illiterate or literate alike. So this is going to be the driver. So it need not. Once the lens stop deforming and creates a presbyopia problem, it is dysfunctional. There are changes in the lens, aberrations get added, the internal aberrations, the quality of vision comes down, there is a photic phenomena. The patient may be 6'6" on the Sneller's chart. We don't use a Pellier option in our OPD, so obviously we are not aware of what the lens has done to the patient's quality of vision. So it is time to now move that we need to work on the dysfunctional lens. And since we are able to do a very good surgery, a very safe surgery, very quick surgery, and that too it is much easier on a clear lens with a better zonules and better capsule behavior, this is something that we need to say. And we are okay that the patient wear glasses. The spectacle independence has been always linked to the elite, has been linked to the rich. No, every patient, if they are able to see far and near and intermediate without glasses, it is a great quality of life enhancer. So this is where we have to work on presbyopia correcting IOLs and the toric counterparts, where we need to make the patient emmetrope and spectacle independent. So this is something that we need to work on. And this is another thing which I've been working for last few years. We always tell the patient there's an asymmetrical cataract. We say get the right eye done, left eye at your convenience you come. We really do not say that both eyes have cataract. There's a binocular vision. Patient has to work with both eyes. So you cannot operate one knee replacement and do the other knee replacement after 2 years. Patient will still be limping. So for the sake of binocular vision, if you say the 2 eyes have to be done with minimum gap, maybe the time for immediate sequential surgery is also in future. So just change the narrative, it will make a big difference. And we are not really making an attempt to dispel the fear or the public myth that is associated cataract. And also we don't really blow a trumpet about the topical phaco. There are a lot of people who can do SICS and claim it to be as equivalent. No, we need to make it very clear in our narrative that topical phaco is the way that anybody should undergo surgery, and obviously other surgeries with a peribulbar block, a scleral tunnel, nucleus coming into the AC, lot of iris and cornea damage potential has to be analyzed, and that is something very important. I think I had doctors in my place who came with presbyopia. They were not happy with their glasses, and they had clear lenses, of course. Some of them were into fitness. They could not wear glasses and run marathons. So this is the time it started that I operated many of the doctor colleagues of mine, and we, with the present day available presbyopic correcting lenses, what we call as Prilex, it has changed their life. I have personal accounts of all these doctors, and they say that this was their best event that happened. Because anyway, they're going to get cataract after 10, 15, 20 years. You just prepone them in their prime of life, they can be spectacle independent. And geriatric patients, that is what we get majority of them, they need more push because they're already socially underprivileged. There's already some caretakers who wants to finish the job with paying lesser package or lesser money. And these old people don't spend money. They always have that austerity or money saving mode in their entire life. Even though they have lots of money in their bank account, they never spend it for eye care. So that is where you need to actually talk to them, and they actually need more push because they always want to go with the lowest package because they think, why anyway, we have got only few years to live. They don't really, even though they have money, they don't spend. I think this is where we need to actually turn it around. And my present narrative is presbyopia is the new menace, and we are not doing enough. If you are a presbyope, you will understand that it is something to see clearly without glasses for near is a great feeling, and the cataract surgery will take care of this with the present lenses. Why do it at 65? Why not at 55? If we can prepone it, why not? And these patients who are really suffering from poor quality of life because of their dependence on glasses, it is something that we need to really look into. Of course, the science of it is something totally a different talk. And advise surgery for both eyes. Binocularity, trying to bring them both eyes, surgery without much gap in between to avoid all the problems of neglected cataract, giving rise to phacomorphic glaucomas and things like that, or the loss of stereopsis because of the cataract in one eye need to be taken care. And they are not doing a favor by getting surgery by you. You think that you are actually doing a favor by changing their life, by giving them the greatest gift of life, that is the sight to all of them. So thank you very much for your patient hearing.
Thank you, Dr. KP. Actually, it is more of communication skill development. I absolutely agree. I was just remembering one case, a combined case we had last week. Patient opted for the highest premium sum lens. There was a PC problem, and we had to put that lesser lens. And I did vitrectomy, everything. Then I went and told the patient, there is backside I am doing some procedure. So the lens you chose was little rigid. So I made another one. No problem, sir, doctor, no problem. So actually, they agreed. And they are, how much I have to pay more? They
exactly.
Said, then I said, no, that is not more. Actually, it is little less. Don't worry about that. Very happy. Otherwise, if the account people tell 45,000 was not put, only 20,000 was put, they will think that we have given a lower quality.
A compromise.
So they were very happy. So this sort of communication, absolutely, I agree with you. You are a master.
No, at the same time, the geriatric population, what I say is simply I just emotionally blackmail them. I said, how many kids you have? There are 4, all of them are America, Australia, they are vice presidents. I say, you have done so much for your kids, for your family. What have you done for yourself? This is the time, you have money, right? I know you are well placed. See, this is the time you spend for yourself. It is found, I have known that with personal experience, a lot of old people leave a lot of money in the bank account and they don't spend it on themselves. And we are doing a favor by actually doing it. It's not a commerce. I'm saying it's a question of morality. The person should be taught to spend for himself, for a better vision.
Absolutely.
See, why wear glasses, have a bifocal and trip on the stairs when he can have a presbyopia correcting eyeball and move around?
Another thing is we keep postponing. We will ask the patient, how are you? Okay, everything fine. Then come next year. Then they keep on aging. After 4 or 5 years, when they come for surgery, they will be very that.
Yeah, they always
age
come with advanced scan. See, that is the thing. We postponing I just change the narrative. I say the both eyes have to be done without much gap. That is the only thing. I am not very coercive. I don't really push too hard. I just tell my sentence that both eyes have to be done. Because some patient asked me, sir, can you do both eyes at the same time?
Yeah.
That was the eye opener for me. Thank
Absolutely.
you.
Thank you. Thank you, Dr. KP. I request Dr. Sirisha Kumar for giving the talk on phakic IOL. Any communication skill development, anybody can directly contact Dr. Krishna Prasad. Anybody in the audience? No questions.
Good morning. My topic is phakic IOL for the beginners. I don't have any financial interest on the topic or the products which I mentioned here. So the goal of any phakic IOL surgery or any refractive surgery is to provide emmetropia without possible change of diffraction in the long follow-up. We have various surgical procedures that are available today, but all have their own merits and limitations. If you see LASIK in high emmetropia, there can be residual errors or there can be loss of best corrected visual acuity. The patients can have poor mesopic vision or poor quality of vision. Whereas in case of phakic IOLs, they have a lot of advantages. It gives excellent refractive accuracy with the preservation of corneal sphericity. We are not going to touch the cornea, so we are maintaining the corneal sphericity and preservation of accommodation. And the healing is highly predictable. And phakic IOLs, the other advantages are like it's reversible and you can adjust. You can just, if there is an axis change, you can just go ahead and rotate the lens and correct the refractive error. And there is rapid recovery, visual recovery and stable postoperative refraction. So these are some of the indications, common indications: high myopia, high hyperopia, or high myopic astigmatism, and even stable keratoconus or treated keratoconus with good best corrected visual acuity. If the patient has 6/6 with the glass correction, these are the right candidates for phakic IOL implantation. And mild to moderate myopia also with limited corneal thickness or corneal weakness. These are the cases wherein we can try phakic lenses. So these are some of the phakic lenses that are available in the market today. I'm not going into the details of these lenses. Better understanding of these lenses is extremely important for with the proper orientation, the lens orientation within the eye. The surgeon should know the position of the lens, and this can result in optimal outcome. If you look at the IPCL, so there are two holes in the optic. These two holes should face superior. If we are dealing with the right eye, then these two holes should be towards your left hand side, and if you are dealing with the left eye, these two holes should be towards your right hand side. And in case of ICL from Star Surgicals, and there are two implantation holes, that is like in the leading right and trailing left. So this should always be followed. The leading right should have the hole and the trailing left should have the hole for proper orientation of the lens within the eye. And phakic IOL candidates require a comprehensive workup to rule out any potential anatomic or physiological problems. So these are some of the basic investigations which we need to do: visual acuity, best corrected acuity, refraction, slit lamp examination, IOP measurement, and fundus examination. ACD and white to white measurement is extremely important, and keratometry, specular microscopy, and topography. These are some of the basic investigations. And we need internal antechamber depth that is for customization of these phakic lenses. And if the ACD is taken from a scan, which measure external antechamber depth, we have to deduct the pachymetry from the whole value. And some equipments like pentacam, it gives internal antechamber depth. So it should be more than 2.8 millimeters. And horizontal white to white measurement from mid limbus to mid limbus is extremely important. So the measurements of white to white distance using a caliper has been proven to be a simple but a reliable method. And we should make sure that the caliper is well calibrated and you pre-treat the eye with the anesthetic drops. Proper calculation and sizing is very important, because sizing will determine the fit and overall success of these phakic lenses. Selecting an appropriate lens size is based on the measurement of patient's white to white distance, which is just an indirect measurement of sulcus to sulcus. There are various instruments that are available for white to white measurement, and the preferred one is, actually, with the experience we have done quite a good number of phakic IOLs. With our experience, I could say that the digital caliper is the best way to measure white to white measurement. It can be cross-checked with the topalizer or pentacam values. And precise definitions for insufficient vault and excessive vault have, however, remained elusive, because only a percentage of eyes with vault beyond any predefined range experiences vault-related adverse events. So if you see here, there's a very low vault in both the cases, but in this particular case, the crystalline lens is very clear, but in this case, it's already started developing anterior subcapsular opacification. And many authors have reported a range of values for the limits of safe vault based on the likelihood that cataract or pupillary block may occur beyond that range. And there are various studies. So the many of these authors have suggested from 150 microns to 1000 microns is the acceptable limit, but we suggest 250 microns to 750 microns is the ideal vault that should be aimed for. And phakic IOL replacement. So this particular study, which was published in JCRS 2015, actually they suggested if the vault is less than 100 microns or greater than 1000 microns, the phakic IOL has to be replaced. And if the lens comes direct contact with the crystalline lens, if there is a shallow AC with the closure of angle in any quadrant, or if the vault is greater than 1000 microns with mid-dilated pupil, and if the patient is symptomatic, having a constant glare. So these are the conditions wherein we have to replace the posterior chamber phakic implant. So there was a meta-analysis which was published in Clinical Ophthalmology, which was published by Doe Press, wherein they have studied 1400 eyes and reported only 4 eyes with anterior subcapsular opacifications, and out of which only 1 patient required surgery. So it is just 0.1% of the entire series. So that is a very small percentage. The chances of anterior subcapsular opacification, if all the rules are followed, is very less. And there are a few more studies which also have shown that there can be anterior subcapsular opacification, but the significant anterior subcapsular opacification which requires surgical management is minimal. This is some of the cases showing anterior subcapsular opacification. This is our own case where the patient had developed anterior subcapsular opacification and needed surgical treatment. not able to. Yeah. So it's very easy actually. You can make a same incision. The incision size should be the same as your phaco incision. 2.4 millimeters is sufficient to remove these lenses. It's highly flexible lenses, and most often these anti-subcapsular opacifications are in young patients. Most of them don't have nuclear sclerosis. It's very easy to aspirate these cataractous lenses and replace it with the posterior chamber intraocular lens. This is another case which is showing a very high vault. The vault here is around 1110, and these are the cases which can lead to symptoms and can have secondary angle closure. And you can see the angles here, so very narrow angles, and this particular patient needs replacement. Another 30 seconds.
Can take another 2-3 minutes.
Okay, okay. So, and needs a replacement. If you yeah. So it's just you have to flip it into the anterior chamber. It's a highly flexible lens. It's not like your intraocular lens wherein you have to cut the lens. Here you can just flip it into the anterior chamber, and with the help of holding forceps, you just pull it through the same incision. It comes out easily without distorting the incision, and then you replace it with the new lens. You need not enlarge the lens, enlarge the incision. And a few case examples. This particular case, the patient has a high myopic astigmatism and it's anisometropia. And the right eye is amblyopic with a very high spherical power, and left eye has 10 diopters of myopic astigmatism, and the right eye 618 is the best corrected visual acuity, left eye is 66, and the anterior chamber depth is sufficient, 2.98 millimeters, the other eye 2.9 millimeters, and this is the toric ICL implantation, toric sheet. And post-operatively, the patient has improved to 612 parts in the right eye and 6.5 in the left eye. So there is actually half a line improvement in the right eye and 1 line improvement in the left eye. Similarly, this particular case is a post-C3R patient who has undergone C3R 5 years back, and he has a residual astigmatism of 3 diopters and a spherical power of 3.75 diopters, but improving to 6/6. So the cone here is almost central. It's not a highly decentered cone, but the visual acuity is improving to 6/6. This has to be understood. Any keratoconus patients, if the visual acuity is good with the glasses, these are the candidates which can be implanted with phakic IOLs. And the post-operatively, the patient is doing well, 6/6 plano. Another third case has got a mixed astigmatism, and the visual acuity is improving to 618 parts, and we suggested Intax plus CXL for this particular patient. You can see a highly decentered cone here, and we have to recenter the cone by doing Intax with the CXL, and post-operatively after Intax plus CXL, the visual acuity has improved to 6/9 because of the recentration of the cone. This is the centered cone now, and the visual acuity has improved to 6/9, and for the residual error we implanted phakic lens. And post-operatively, the patient is doing well. The uncorrected visual acuity has improved from 5/60 to 6/9, and post-operatively, with the best corrected visual acuity, it is 6/9. And the loading of these lenses is extremely important. is extremely important, and if these company people will come and demonstrate how to load these lenses, because the proper orientation of these lenses in the antechamber is extremely important. To conclude, acute preoperative measurements can give rise to perfect vision after phakic IOLs, and there has been improvements in best corrected visual acuity up to 1 to 2 lines. And the quality of vision can be great by preserving accommodation and maintaining a corneal sphericity. Thank you very much.
Thank you, Dr. Srishakumar. Since Dr. Mohan Rajan has not turned up, we wind up this session. Before that, any questions to Dr. Srishakumar?